May I invite Dr. Faouzi Saliba, I hope I'm pronouncing the name right, for a talk on once-a-day immunosuppression, the pros and cons. And I think it's extremely relevant for us. Patient compliance will improve tremendously, and we look forward to listening from this. Dr. Faouzi, please.
Mr. Chairman, dear colleagues, I would like first to thank the organizers for this invitation to the hepatology courses in India. These are my disclosures. So, for the once daily prolonged release tacrolimus in comparison to the BID or twice daily use of tacrolimus, and this is where I will only highlight my topic. There have been a huge number of trials during the last decade on such a topic, but we'll try to summarize the important points. Two main points to highlight: the PK data comparing once daily versus BID. We know well that tacrolimus had a narrow therapeutic index. That means between efficacy and toxicity, the grade is very low. TAC-PK also, in addition, had a large intra and inter-individually variation, and this is related to the metabolism mainly by P450 cytochrome. Therefore, for all transplant patients, there is a high need for therapeutic drug monitoring of drug levels daily in the first early period of liver transplantation, and then at each time of visit or consultation. And always dose adjustment are mandatory. The first message we can say, if we can do a little bit summary of all what have been published, that PK differences between once daily and BID mostly carry on absorption and do not carry on the metabolism and the excretion of the drug. And several studies reported now very strong and similar correlation between the trough levels and the 24 hours area under the curve. That way we can continue doing trough levels either with BID formula or once daily formula. The magnitude of certitude is similar. And the second major topic that highlights the need of once daily is compliance and adhesion treatment. Just to know that the prevalence of non-adherence to immunosuppressive medication may range from 8 to 10% till 20%. It's mainly high in pediatric and adolescent patients. The time at adolescence is very critical. In young adult patients transplanted mainly for acute liver failure or other liver disease, this is also critical. And you have many other factors that could lead also to non-compliance and non-adhesion to treatment related to social factors, psychological factors, addiction, and adverse event. Compliance to medication also might decline over time when we go 3, 5, 10, and 15 years. This probably contributes what we know now to either late acute rejection or probably antibody-mediated chronic rejection, which now the definition is not quite sure, but we have now many data, mainly in the young patients on chronic rejection, may probably related to less compliance. We will not follow all studies on these issues, but we know that several studies reported improvement in compliance and adhesion to treatment for TAC once daily. I will go on only the main few studies important on this issue. The most important one this was a prospective randomized multi-center double-blind study. 471 patients randomized either to the TAC BID group plus corticosteroids, 234 patients, or to the TAC once daily. And you can see for the tacrolimus BID here and the tacrolimus once daily on the upper curve, there is These are the mean trough total daily dosage in the upper curve, and we can see that you need more dosing, mainly in the first period to adjust, and the large variation to adjust your trough levels as compared to the latest period. But overall, if you look at the mean trough levels, also there are more variations in the mean trough levels during the first months when you compare later on in the treatment. And this is an important point when you want to use both formulation. When you look at the data on efficacy on renal, this is GFR, creatinine clearance was comparable among the two groups. Risk of biopsy-proven acute rejection was comparable. This study was in 2010. Maybe the rate of rejection at that time was slightly higher than today. And there is no MMF. This is dual therapy, not triple therapy. This is why we can expect a higher risk of rejection and renal impairment too. This is the main large pivotal study, the DIAMOND study, that compared the Advagraph, which is the once daily dose, in three settings, in order to see can we use the once daily formulation early in the immediate period post-transplant. And you can see that the first arm was to use tacrolimus once daily at the dose of 0.2 milligram per kilo per day plus MMF. Arm 2 and Arm 3, they included induction therapy with basiliximab and reduced dose of TAC between 0.15 milligram per kilo per day, and the Arm 3 similar, but delaying introduction of CNI. And the data, we know these were around 900 patients, around 300 patients in each group. When we look at the tacrolimus, the trough levels of tacrolimus, the three groups are once daily formulation. You can see in the Arm 1, the highest dose, 0.2, it was high. The trough levels was really high here compared to the induction therapy where we used lower levels. And this is variation in the levels always during the first months. Similar here, we can see the trough levels of C0 from day 0 till day 35. You can see more variations during the early period, especially the first 2 weeks. And here also most unfavorable to use the induction therapy and lowering dose of TAC. If you look at the data on GEGFR at week 24, on the MDRD, with the Arm 1 without induction therapy and higher dose of TAC, you have higher, the renal function was at you can see the Arm 1, the renal function was the worst, around 67 milliliter per minute at week 24. And you compare the two arms here in orange and green with induction therapy and lower dose have significantly better eGFR. This is important when the extension data have been published later on in AGT and focusing on renal function, dividing group of patients with eGFR above 60 and below 60. If you look at between the randomization and week 24, as with always, we are using CNI, we were losing eGFR by 30 milliliter per minute. You see, we went from 100 milliliter normal eGFR at time of randomization to around 65. But the worst you lose eGFR was Arm 1, where you are not using induction and higher dose of TAC. It's similar. If you look at those patients with CKD, chronic kidney disease, as defined by eGFR below 60, you can have improvement in some degree of renal function from 36 to 48, but the best improvement were in induction therapy and lower dose of CNI compared to the Arm 1. If you look this is just to summarize all studies, 7 randomized controlled studies that try to compare once daily tacrolimus to twice daily tacrolimus, and you can see that all these data showed that comparing the two drugs, there was no difference on outcomes, neither on acute graft rejection, neither on the main safety issues like occurrence of infection, any adverse drug reactions, headache, back pain, and blood disorders. Most of these studies were only 1 year or 2 years period. But the most important data we have from the European Liver Transplant Registry that analyzed patients transplanted from 2008 till 2012, that nearly around 4,000 patients. And they divided those who were already started prolonged release TAC to tacrolimus BID. And at the end, they did a propensity score matching 1 to 2, and they compared 270 patients with once daily tacrolimus to 500 with BID. And they did show that finally on the long term, maybe not on the first year, but on 5 years, on 3 years here, patient survival and graft survival were significantly better when used the once daily formula. I would show you better the study that continue. This was the extension study, also from the till 2016 this time, also from the European Liver Transplant Registry, 13,000 patients. And they divided those who prolonged release tacrolimus versus intermittent release BID. And they did a propensity score matching using around 18 variables that we know that all could affect significantly outcome, like the MELD score, the Donner, Ishtar characteristics, the Immunosuppression score, ischemia time, graft preservation solutions, and also immunosuppression, whatever. And finally, they compared 3,000 patients with 1,000 patients once daily and 2,000 intermittent release BID. And you can see here that on the long term, and here we have the data on 4 years graft survival and 4 years patient survival, you have significant differences in favor of the once daily, around 5 to 6% differences in both graft and patient survival. And when you look also after, this is before, when after cross-matching calibration, the things remain, that you still have even better, more differences when you really calibrate according to confounding factors. You still have differences in favor of the once daily tacrolimus compared to the BID. And in the multivariate analysis that analyzed predictive risk factors of reducing graft survival or patient survival, you can see factors. We know that recipient age, the emergency status of the liver transplant, renal impairment could affect graft survival, but also the use of BID tacrolimus immunotherapy was affected also too with increased graft loss, but also with increased with decreased patient survival. So what also I would like to say, if we want to calculate the need to treat, the number of patients need to treat to save one graft or patient survival, if you took other clinical examples, for example, you need to, if you do prevention with statins, you need to treat 35 patients to avoid a cardiac event. If you do flu vaccine, for example, you need to treat 23 patients to avoid a flu event. Also for osteoporosis, we know that we need to treat around 20 patients to avoid a hip fracture, 3 years hip fracture risk. And similar issue, and also here to save one graft or a patient survival, one graft loss, you need to treat 14 patients, you can avoid one graft loss. So this is an important benefit on the long term. Overall, I would summarize and conclude. If you want to say about the con on the use of tacrolimus prolonged release, sure, there has been some issues and debate in the early phase of liver transplantation, in the post-transplant setting, in the ICU or immediate hospitalization. I had difficulties to adjust the levels. So dose adjustment was more frequently required. This is in a study, for example, 73% you need to dose adjustment in once daily versus 43. The second point that TAC once daily is associated with an increased risk of disturbed absorption. So in patients with diarrhea or change in intestinal motility or paralytic ileus postoperative, you can have also need to adjust more frequently. So more cautions and the rapid dose adjustments might be needed also in patients who develop surgical complication or, like, for example, postoperative bleeding, re-intervention. You need to stop the drug, acute kidney injury, you need more adjustment. So probably this maybe 20 or 30% proportion of patients would most likely suffer a little bit more from using the TAC once daily early, but we do not have real evidence on this, to be honest. Finally, the patient perception to switch to the compliance is important. So if when the patient in the early period has multiple drug, 2 or 3 times daily, so the patient by himself will not see the benefits of to use once daily compared twice daily. But on the long term, when the number of drugs has been reduced, probably the benefit and the perception of patients is better. For the Pro, finally, there has been similar efficacy and safety profile overall was found with the both immediate release and prolonged release TAC. Either also data we have studies in living donor liver transplantation as well as in cadaveric donor, similar results. On the mid and long-term follow-up, compliance is important. Non-adherence, mainly in pediatric and young adolescents, and some other factors that we could mention, could lead to antibody-mediated rejection also and late rejection. Finally, I will conclude to say that prolonged release tacrolimus will improve adherence to treatment and reduce variability to tacrolimus exposure. Conversion from intermittent release to prolonged release after 1 month or during before discharging the patient, or starting at the beginning with prolonged TAC-based immunosuppression, were found both to be associated with better graft and patient survival at 3 to 4 years. Thank you.
Thank you, Dr. Faouzi. That was a very informative talk. Do we have any questions? So I had one question in the meantime. If one was to give intermittent dosing like 2 milligram in the morning and 3 milligram in the evening, would the trough level change if we were to reverse the dosing, especially when the patient is not getting the same dose morning, evening for the intermittent dosing?
Yeah, this is a frequent situation that might occur, sure. Here you are more, in general, adjusting your trough levels on the BID on the dose of 3 milligram rather than the dose of 2 milligram. So in such situations, sometimes we are giving the patients one in BID like 2.5 to really know the real trough level. But in the situation converting from the once daily formula, we just calculate the 5 milligram and we switch to 5 milligram once daily. Unless you are using other formulas like extended release, the melt dose LCP, this is different because the absorption here is higher of such TAC formula. You might need to lower the dose. There is like 0.7 milligram. It's in the Caucasian population, and it's 0.80 or 85 in the Black population, has been calculated on previous PK trials.
Thank you, Faouzi. It was a fantastic talk, and I must thank you once again. One question to you was, like, once you start once daily early on post-transplant, and if patients have complications like bleeding or biliary leak, and they need interventions, they may have to go to the theater again. So in such situations, how do you manage them? Like, do you give a break to that once daily, go back to twice daily, or or you have some other strategy? Because this is sometimes seen in 10, 20, 30% of patients, which you mentioned yourself. So how do you handle that critical phase when you're not able to administer once daily in your normal way?
Oh, this is what the This is an important question and has been raised with the company since the beginning. Intensivists like I too, we are reluctant to use prolonged drugs because we calculated that to know the real trough level of the dose you give this morning, you need to wait the second day in the evening. So if the patient develop a complication, you need to intervene, or acute kidney injury, you are losing like 12 to 24 hours to readjust your dose. And like I showed, these patients in general, did need a lot of adjustment in the early period, according to especially if it is a living donor, if it is a split donor, if it is a fast inducer or a slow inducer, according to the genetics of the cytochrome P450. So I'm not sure. So usually in our center, we started when the patient is very steady. That means he's left the ICU, he's in the hospital, and just a few days before discharge. So in general, we move on to the once daily like 2 weeks after or 3 weeks. If you see the patient is stable, this could be the right time. But like I said, these are few populations that move a lot and you need a lot of adjustment. Now we are transplanting patients with very high MALD score, with renal impairment, higher risk of bleeding. So difficult to adjust the once daily, whatever for CNI and even other formulas.
Thank you so much.